While there's no cure for most of the diseases that cause dementia, there are many things that we, as clinicians, can do to improve a patient's quality of life. My name is Jessica De Leon, and I'm a behavioral neurologist. In previous videos, we reviewed what dementia is and how to normalize screening. Now, we will talk about how to diagnose dementia. A quick note about this video, this is not going to be a detailed review of how to make a diagnosis. What you will learn from this video is what the components are and how you can start to feel confident that you know enough about them to make a diagnosis. But first, a quick reminder of what dementia is. Dementia is a syndrome, most often caused by one of many neurodegenerative diseases. It presents as cognitive decline, severe enough to be affecting function, and it's acquired. Symptoms are new and progressive. So, when it comes to the core diagnostic criteria, we are looking for evidence of acquired cognitive decline and acquired functional decline, both compared to a premorbid baseline. So, how do we determine a premorbid baseline? Let's talk about the first component in making a diagnosis: history and exam for both cognition and function. Let's pause for a second and do a quick review of what we mean by cognition and function. For cognition, the DSM-5 lists 6 domains to consider. It's easy to think only of memory here because memory loss is a very common symptom of the most prominent cause of dementia, Alzheimer's disease. But there are other cognitive domains like attention, executive functioning, language, motor control, and behavior that can be affected. As for function, we need to understand how the patient functions day to day, paying attention to their history and collateral history, meaning history gathered from someone other than the patient. So back to this first component. As part of our exam, or any gathering of history, we need to assess cognition and function for 3 characteristics. The first characteristic is onset of symptoms. Are these symptoms new? Establish that these are not lifelong. You might ask, when you think about your life 2 years ago, were you having these symptoms? Or have you always had challenges with remembering people's names? The second is trajectory. Are these symptoms getting worse? Establish that there is a trajectory of decline progression. You might ask, think back to last Thanksgiving or the Thanksgiving before that. Were you having as much trouble cooking? And finally, the third characteristic, severity. How are they affecting this person? The more severe, the more likely they are to be in the abnormal range. You might ask, how often are you having this difficulty remembering conversations? Would you say it is affecting you more and more? History is a huge part of the information we gather, and this is an overview. Our website has more detailed guides on what questions to ask to get a patient's history of cognition and function. Another component is objective data. Examples are cognitive testing with neuropsychology or observed functional assessments, for example, by occupational therapists. It may also be appropriate or not. For example, if you meet someone who is very impaired, it may not be possible or necessary to get a neuropsychological test. Included in objective data is labs and imaging. For example, labs might reveal reversible causes of dementia, or a brain scan might show evidence of neurodegeneration, like patterns of atrophy, vascular disease, etc. The third component of making a diagnosis is a review of comorbidities. Could this be impacting cognition? For example, do they have sleep apnea? Do they use substances? Do they have a serious mental illness? Or are they on medications? These things don't cause dementia, but may be affecting cognition. Lastly, we need to look for red flags that increase the urgency for care. Look at this list of red flags for a moment. It's important to know that there are symptoms that can mean a more urgent specialist evaluation and brain imaging is needed. If you detect any of these, it is recommended to refer to a specialist, like a neurologist or geriatrician. For further support and clinical resources, there is a list of toolkits on our website with links that offer step-by-step guidance. So to review, there are 3 main components to making a diagnosis: history and exam, objective data, and review of comorbidities. By examining those, you can establish a premorbid baseline and determine if your patient's symptoms of cognitive and functional decline are new and progressive. You should also understand now how your assessment of onset of symptoms, trajectory, and severity of the symptoms will also inform your diagnosis.